Good morning. My name is Julie Burns, and I am the President and CEO of RIZE Massachusetts Foundation, and I want to welcome you to today's program, Learning from Lived Experience, Understanding Barriers to Recovery. Before we get started, just a few announcements. All participants will be on mute throughout the program. Questions can be directed during the discussion by using the chat option on your toolbar. Please feel free to send your questions throughout. You can also access closed captioning by clicking the live transcript button, and the webinar is being recorded. We are also live tweeting the event, and please join us in the conversation and follow us on Twitter. Our handles are @RizeMass and @C4 Innovates, and we'll be using the hashtags Recover Your Barrier and Zero Stigma, Zero Deaths for today's program. Finally, you'll receive a survey at the conclusion of today's event, and I hope you'll take a minute to fill it out to help us inform future programs. We had over 400 people registered for today's event. Some of you are new to RIZE, so a bit of background. Launched in 2017, RIZE is an independent nonprofit foundation created to end the overdose epidemic. We're made up of a constantly growing group of providers, payers, unions, advocates, and people with lived experience who are equity-minded, entrepreneurial, collaborative, and dogged in pursuit of our mission, Zero Stigma, Zero Deaths. One of our strategies to end the overdose crisis is to serve as a neutral convener, bring people together, share learnings, support exploration, enable change, and that's our goal for today. An example of this work is our Together in Recovery initiative, of which this paper is a byproduct. Launched in 2019, Together in Recovery is designed to foster an accessible, integrated treatment and recovery network in Massachusetts that champions evidence-based approaches, supports multiple pathways to treatment, and puts people in charge of the decisions about their treatment. We're honored to be partnering with C4 Innovations for today's program. C4 also serves as our main collaborator in the Together in Recovery initiative, and I'd like to thank the entire C4 team for your partnership. Now I'd like to give you a little bit of context about the paper we're sharing today, Learning from Lived Experience, Understanding Barriers to Opioid Use Disorder Recovery. After experiencing one of the highest opioid-related death rates in the country, Massachusetts has become a national leader in responding to the opioid overdose epidemic, and much improvement has happened in recent years. And that's a testament to all of you, providers and people on the front lines whose dedication and commitment is unparalleled, especially in times of crisis. Expansion of insurance benefits for addiction treatment, increased access to medications, reduced opioid prescriptions, improved provider trainings and education, and addressing stigma are all areas where we've seen great progress. And during the height of the pandemic, changes to federal guidelines also improved access to methadone and permitted opioid treatment programs to offer mobile services. And I think we all learned that these temporary solutions should be made permanent. However, despite these advances to remove barriers, the overdose crisis has worsened, exacerbated by the pandemic. In 2020, Massachusetts opioid-related deaths rose by 5% and then by 1% in 2021. Grief, isolation, financial and job losses, and disruptions to treatment are factors that have contributed to record level of overdose deaths, erasing gains made before COVID-19. Communities of color were especially hard hit. Black men in Massachusetts saw a 69% spike in overdose deaths over the last year, which is the highest increase observed in any ethnic or racial group during the pandemic. A 2020 National Academy of Medicine paper focused on addressing barriers to accessing opioid use disorder treatment found that there is insufficient attention to understanding the perspectives of people who use drugs and the obstacles they face accessing treatment. Considering that approximately 70% of those who need treatment do not receive it, people who use drugs must be part of the conversations to better understand their experiences and to design services that meet their needs. You'll have the chance to discuss some of those challenges today with those who have experienced them firsthand. Obstacles like a lack of evidence-based knowledge or information about multiple pathways to treatment and recovery, myths and misinformation about medication for opioid use disorder treatment, lack of discharge planning, warm handoffs, or continuity of care at key transition points such as leaving inpatient treatment, post-overdose, leaving the hospital ER, or incarceration. Limited availability of individualized treatment, including family-centered, general-specific, bilingual, and culturally responsive treatment services, and a limited availability of services in rural and historically marginalized communities. By sharing the nuanced and varied experience of the individuals interviewed for our paper, Joseph, Kelly, Christian, Roberto, Brian, and Shannon, Shannon is here with us today for the panel, we hope to better understand the barriers, improve the care experience, and ultimately save more lives. I'd like to thank all of the people interviewed for trusting us with their stories and experiences. Those closest to the problem know most about the solutions, yet they are often farthest from decision-making, and that's why we chose to bring forward their stories. We're also incredibly fortunate today to have today's panel who can offer guidance and lessons learned about breaking down barriers to recover. Sharon DiNardo, who I mentioned participating in our white paper, is a harm reductionist and recovery coach, her 7th year in the field. Danny Rodriguez is Director of Substance Use Disorder Services at Duffy Health Center in Barnstable. Danny provides clinical oversight for the health center's substance use disorder services and leads related projects, including Duffy's Moms Do Care program and the NIH-funded Healing Communities Study Chart mobile project. And Lisa Blanchard is Vice President for Clinical Services for Spectrum with over 18 years experience in behavioral health administration, including new program development and electronic health records implementation. Lisa also serves on RIZE's Together in Recovery Advisory Committee. So a special thank you to our panelists for sharing your expertise and knowledge today. And now I will turn it over to the man who needs no introduction, Daryl McGraw from C4, who will moderate the discussion today. Daryl?
Thank you, Julie. Thank you. I'm so excited. I was jumping out my seat. I'm getting ready. Julie, I want to thank you, and I want to thank RIZE and our Together in Recovery team for bringing this together. I hope each and every one of you are excited about this conversation today. I like to get the chat box on fire. I don't know about y'all, but I like to get it started, right? So what I need you to do, if you're a person in recovery, say I'm a person in recovery. Doesn't matter what you're in recovery from. I believe everybody's in recovery from something. So let's jump in right in. I got an amazing panel, but just a little bit about myself. My name is Daryl McGraw. I'm a person in long-term recovery, which that means that I have not used a substance since May 7, 2007. That also means that's the last time I've been in the back of a police car. So my story also is involved with the criminal justice system, and I'm also a trauma survivor. Y'all getting ready for this? Because this is real talk, because we don't get invited a lot of times to these conversations. So this is why I ask you to identify so they understand that we not only want to sit at the table, we want to build these tables. So y'all ready, man? I got a strong panel. We got Shannon, we got Lisa, and we got Daniel. We're going to rip it down. If you ready, just let us know you're ready, man. Let's get this thing going. Daniel, how you doing, brother?
I'm doing well and couldn't find the unmute button, but doing very well. Thank you.
Oh, no problem. You in the building. Shannon, you in the building? Where you at, Shannon? Shannon, you got your mute button. I'd like to check everybody, make sure we're here. Unmute yourself, Shannon and Lisa. Where you at?
I'm so sorry. It wouldn't let me unmute. Good morning. How is everyone? I am absolutely ecstatic to be here.
Let's go. I see you, Ashley. Let's get it. Keep that chat box going. I like to keep people working. Lisa, where you at? You here, Lisa?
I'm right here. Finally got the ability to unmute. Really happy to be here. Really happy for this conversation. Thanks, Daryl.
Okay, cool. We're going to be talking about some questions, and those of you that are here and you can hear my voice, I want you to keep the chat box on fire. So if you got questions about some of the barriers and challenges that you face wherever you at in this country and you doing this work, because each and every one of us are privileged to do this work. When we do this work, right, people live, people alive. And not only do they live, I don't believe in just living, they get to not only survive, we want people to get to thrive. So this is where we're trying to go today with these conversations. And I just want to start off with the question of, I like, Dan, you're gonna have to wait, man. I'm gonna let the ladies go first if you don't mind, but let's talk about some of the barriers and challenges that you face or that you have faced or your clients or people that you work with have faced with the system, because we want to put the system on their heels. If we don't have these conversations, then we can't make change. Shannon, would you like to go first and talk about some of these barriers that you may have faced in the work and the challenges on your journey?
A lot of the barriers that I face is the stigma, right? Like you said, Daryl, a lot of us that are in long-term recovery tend to have a record, and being in the back of a police car or being looked at differently from everyone else in the world, it stinks, right? It's between me and the people that I work with, having someone else, especially that is in recovery themselves, look down upon you, it's horrible. It makes you feel horrible. One of the things that I've struggled with the biggest is going to the meetings and trying to find support from others that are like me, that have gone through the similar experiences that I have, and then finding out that I'm on Suboxone, and then being told I'm not clean or I'm not in recovery. So that's huge for me, because I, regardless if you're on a medicine or not, whatever your road to recovery is, you are in recovery, period. There is no but or wait or this or that. If you're in recovery and you say you're in recovery, no matter what your road looks like, you are in recovery, in my opinion.
Oh man, Shannon, you already trying to start some trouble already. Let's go. Let's get it. You already cranking it off. We definitely believe in multiple pathways to recovery. And we want to make sure if you work in an organization and you face some challenges, barriers, or what have you. But Shannon, I love the way you kicked it off with the stigma, because sometimes an address can be a stigma, right? If you come from a certain area, they automatically think you're pill searching or you're doing this or so on and so forth. Thank you for I know my brother Steven loves that stigma word. Lisa, what you got? What we doing?
I'd love to, add to what Shannon had to say from her perspective, right? Running multiple treatment programs in the state of Massachusetts that provide medications for opiate use disorder, right? Like, we also, even in the treatment recovery, are stigmatized, particularly with methadone treatment, and not seen as appropriate, balanced care that it is, and available to folks. And our patients feel that, right? So I know that if I'm feeling that, I know that our patients are feeling that even more, and that we run into challenges when we're opening programs and trying to be in certain areas or buildings, or managing parking, or in the community. Often, our treatment programs, and by that, the individuals that are in our care, are often stigmatized, and anything that happens in that community can really be, in some ways kind of, blamed on our patients because of stigma, and not seeing our treatment as the evidence-based care that it really is. And that can make it difficult for folks to move through the system and work towards long-term recovery.
I love it, Lisa. I love what you're saying. Dan, you see where we're going. You see where we're taking this, right? Let's go with it, man. What you got, brother?
You guys will get to know me very well. I could talk all day, and thank you for letting the women go first, because it could be a while. But two things really come to my mind. For folks who are geographically not inclined to know, our region here on Cape, we are an island, man-made island. We are typically seen as an affluent community because everyone and their mom comes to Cape Cod to vacation and to go to the beaches. But we are a fairly rural community with hardworking individuals who have a lot of impoverished, community members, and folks living, well below socioeconomic, status, in a lower socioeconomic status than folks lead to believe. So the reason why I wanted to say that is because when it comes to looking at treatment, there are a multitude of barriers that we face here, which includes the fact that we don't have a lot of resources, for inpatient beds, trying to get folks to the care that they deserve. If we're trying to get someone to a medication for opiate use disorder clinic, an OTP for methadone, the expectation is that they're driving 30, 40 miles to get there. In addition to that, Duffy Health Center, we serve folks that are actively homeless or struggling with housing instability. Our folks are going to the pharmacy and may lack an ID, or may look a certain type of way, kind of like Shannon was saying. And they're being shut down at the door and saying, oh, well, since you don't have an ID and we can't know who you are, then guess what? You don't get your meds, figure it out, or find someone to come help you. So just the continued stigma, the fact that as always, there's this perception that folks either in recovery or struggling with substance use are kind of a lower class, and then couple that with the fact that now you're living in a wealthy community. There are a lot of ways in which our folks are disenfranchised.
Man, brother, I really appreciate that. And just I want to acknowledge that it is Women's History Month. So we are going to shout out all the powerful women, me being a product of a single mom, right? So shout out to all the single moms that are in the room, because I am a product of a single mom. My mom worked hard for me to sit in this seat today. So let me tell you, I'm definitely shouting out our women today. And while we're here, and everybody that's in this room that can hear us, right? Understand we're going to move forward eventually to breakout rooms. And what we want to do, this is not, we never, I don't know if y'all know, but we don't just talk about problems, we talk about solutions, right? So we want you to bring solutions, some creative ways. I know I worked in nonprofits, and sometimes we got a little bit of duct tape and a piece of bubble gum to keep the program together, but we figure out ways that are challenging, that bring people together to help people move forward. So I want you to bring any creative ways. I want to make sure that you can pop them in the chat box. You can talk about them, anything that you've done to overcome some of these systemic, right? Because it's the system. Can we keep it a buck? Can we keep it 100? It's early in the morning, but we're going to keep it real, right? It's the system that creates these challenges, which is why I'm always glad to be part of the RIZE and the C4 family, because we face that head on. So let's talk a little bit more about the challenges, some more challenges, but then I want to jump right into solutions. Some of the ways that you've overcome some of these barriers, and some of them maybe still like you're still working on them. So anybody want to talk about, I'm not even going to, we already done the intro. They know who we are. So if you want to just unmute yourself and talk about that, let's go, man. Let's get it. Daniel, me and you both talk a lot. So, you know, I'm trying to refrain myself, brother.
I'm happy to add to kind of some of the system and program challenges that really make it more difficult for folks to access care. And so what can be really challenging, especially if somebody's on a medication, that they can't just seamlessly go from inpatient levels of care to the next levels, to across outpatient, to the healthcare system. And you know, we've tried to do a lot of things to support that, working with skilled nursing facilities and working with our healthcare partners, but there's still things that get in the way, right? Things that shouldn't get in the way of patient care, like regulations and rules and things that make it just more challenging for folks to just continue their medication. And I think methadone is probably a great example of that, because I like to say it's like the most highly regulated service out there, but not really for good reason, in that it's stigma that I think perpetuates a lot of those regulatory requirements that really hold us, you know, in difficult spots to let people continue their medication. There's no other medication kind of in the world that you can't continue when you move across the healthcare system. Right. And so that I'd say that is one of the biggest challenges.
Man, I don't know if y'all know, man, I'm loving Lisa in the room right now, because she's talking real talk, right? Because a lot of times we don't talk enough about this. And, you know, sometimes it's somebody in the insurance company making a decision on how long or what medication. They have no clue, no medical degree, but they tell you who should be where. So I really appreciate you pointing that out. I want to point out, you're going to see this poll coming up. Programs, people, if you're a people person, programs, people, and systems, right? You're going to jump into those breakout rooms. So pick where you fit, where you see yourself fit, and your expertise. Come and bring that knowledge, because like I said, this is about solutions too, because each and every one of us, I believe together, we're going to make some change. And this is why I love working in this group. Anybody, Shannon, Daniel, want to add to some of that barrier stuff that we were just talking about? Let's go.
Yeah, I would definitely love to add. One of the things that I love doing is help people in recovery advocate for themselves. One of the things that I came across in my early recovery, believe it or not, for any of you that have had the chance to talk to me beforehand, I'm like Daniel, I could talk for hours on end, and I tend to have no filter sometimes when it's something that means something to me. But in my early recovery, I was the person hiding in the back of the room. I didn't know how to speak up for myself. I am a DV survivor. So I have been taught to just shut up no matter what I was feeling. So I love working with people that have survived similar situations and teach them how to start loving themselves again. And that when they're uncomfortable or somebody says something to them, to speak up, no matter the looks you're going to get, no matter the side eye that you're going to get, and no matter what people are going to whisper in this, you know, the back of the room. If you're uncomfortable in a situation, or you don't like the way somebody's treating you, you have to speak up. So I love working with people and helping them understand and to begin to start doing that.
Right, I appreciate that. Appreciate that, Shannon. Hey, Shannon, let me remind you, yo, this is a family show, right? This is in the morning, so you got to be easy. That's the other show at night. That when we, after dark, we start going. Daniel, what you got? What you got, brother?
All right, so I got a couple of thoughts to piggyback off what Lisa and Shannon have shared. And I would say, a closed mouth doesn't get fed, right? So I think that one of the biggest things is advocacy and, continuing to be very vocal about, what the needs are and how to get those addressed. I have to say that I am incredibly blessed at Duffy, that I have an incredible team of individuals with lived experience who are recovery support navigators or recovery coaches that work day in and day out to support our folks here and to try to break down all the barriers out there to, the patients that we serve across all avenues of, treatment, community, et cetera, et cetera. And another systems issue that we see a lot of, and not trying to call anybody out here, is emergency room level of care or support tends to be a very challenging space for the folks that we serve. And what we've seen is that we have individuals who go in either looking for medications for opiate use disorder, or are being brought in after an opioid overdose and are being treated poorly, and B, are never being offered the opportunity to start a medication that may be life sustaining, and trying to figure out how to have meaningful conversations with the systems around us to be able to break through some of that is really important. And also, as I said early on, I'm not a quiet person. We're not quiet people. We literally will squeeze ourselves into any conversation necessary to be able to ensure that the voice of our patients, the voice of our folks in recovery, the needs of our individuals who deserve the care that they need is being heard. So, proud and mighty is what is incredibly important. So advocacy, advocacy, advocacy.
Absolutely. And I really appreciate you saying that. I'm watching this chat box and that advocacy. We need to be that loudest voice in the room because, sometimes they start talking about telehealth, right? Telehealth is nice if you have internet, if you got a phone, if you can be access, you can connect to people. So sometimes you got to still be in the trenches. I love what you said about the ER, right? And one of the things is that bringing peers and people with lived experience into the ER is not only helpful to our people who are in early need of services and connection, but it also changes the culture within the hospital setting. Y'all know what I'm talking about? If you know what I'm talking about, give me a thumbs up, man. Y'all know what I'm talking about. Make sure I ain't talking to myself. Let me know, right? Virtual, however you do it. I want to make sure that we right on the same path, because sometimes I step into the wrong room, right? But I want you to understanding that, it's about connection. It's about humanity. Those of you that are in recovery, this is about lived experience. We cannot say, oh, well, they don't ever ask us, because today we're asking you, right? And that lived experience also comes from, you might not have a lived experience with substances, but you have a lot of lived experience with working in the system. And those voices cannot be silent either. This is a we thing, right? So this is us coming together. This is systems and people in recovery coming together to try to make change for those that are struggling. Because let me tell you something, my friends, there's somebody that's dope sick while we're sitting here looking pretty on Zoom. There's someone dope sick right now, wishing and praying in a foxhole that they had somewhere to go, and they're not going to be stigmatized, and they're going to have a place to go, and that somebody like us is going to greet them at the door. Man, listen, y'all getting me started, man. Where we going next, man? Let's talk about, can we, I'm running out of time. They're going to start tapping and watching, cutting me off. Can we talk about some of the solutions, some of the creative things that you guys have done to greet my brothers and sisters who are still struggling and coming through your doors? Oh, Lisa, I see you getting smile. I see the smile. Let's go, Lisa. What you got?
Yeah, I can also talk all day about some of these things, but I think really relevant to what Daniel just said, right? We actually, of course, we want folks to receive appropriate care, non-stigmatized, supportive care in everywhere they walk in, right, into the ED. We actually don't want people to have to go to an emergency room. None of us want to go to the emergency room unless we absolutely have to, unless it's 3 a.m. and there's no other option, right? We don't want to have to do that. So we shouldn't be asking those that need support that the only pathway that they have to get immediate help is an emergency department, right? And so to that end, we have done a couple of things at Spectrum to do rapid access. So all of our opiate treatment programs have had walk-in admissions for over a decade. And so it's not every single day because regulations and all the things that we have not been able to overcome, but we can change our system and change our program to be, all you have to do is show up and we'll take care of the rest. No scheduling appointments, no multiple steps, right? So you can walk in, to one of our programs and receive methadone that same day, right? Get all of those steps done and be on the program by the end of the day. And that's had a huge impact on the level of access and the amount of folks that we've been able to serve, right? Significant increases because we just took away that barrier of making people jump through hoops just to get care that they deserve. And similarly, for buprenorphine and naltrexone, we have opened now our second, one in Worcester and now our second in Framingham, hub and spoke kind of rapid access programs in the communities that we're in, providing access to buprenorphine and naltrexone in the same way, but multiple admissions per week. And so that you don't have to go to the ED, but if you do, then you can quickly stay connected, right? Instead of just getting, here's your short 3-day prescription, good luck finding a provider. We can hold people for as long as they need to be, right? And then connect them to the care that they want, whether it's staying with us or it's going back to their primary care or going back to their community, wherever it is that they want care, they can access it in the community.
Man, I love that, Lisa. Hey, can we keep it real for a quick second? I know I'm getting short, right? But let me tell you something. Lisa, you're my girl, right? Understand this. When I walk into the ED, my treatment may be a little different than yours because my skin color is a little darker, right? So this addiction, this treatment, this recovery that you guys talk about sometimes is a fantasy to some people of color, right? Because, right, I might look a little different. I might not speak the language, right? I might not understand what you're talking about. So I want those of you that are going to be in these breakout rooms, tell me how you diversify. How do you meet people with color? How are you meeting the homeless? How are you meeting those people that just don't freely walk into the ER, right? I want to make sure that we're making sure that diversity is at the top, because if you know C4, we always are trying to end C4 RIZE. We're trying to end racism at all times, right? End racism, the systemic racism that these structures tend to stand on, right? Because these structures are built, but they were built, they still got they still got a lot of work to do. I'm not even going to say a little, I'm going to say a lot of work to do when it comes to embracing people of color, right? So I just want to make sure that we talk about that. They're giving me the how much time we got. They like to kick me off the stage quick. So listen, Shannon, Daniel, anything, because I want to make sure that we're definitely talking about the paper, because those of you that really like to read and really like that data stuff, I got Cheryl coming up next, and I'm telling you, we're going to talk about the paper next. But any other things that you guys have done creatively really quickly before we move on to the next panel? This has been we could do this all day. I don't know why this is not a conference. Where's Julie at, man? Tell Julie this needs to be a conference all day.
One of the things that I have done is brought different types of recovery meetings to the area where I'm at, out in Townsend, Mass. I started an all recovery meeting on Friday nights. In a recovery, you always hear about AA and NA, but you don't hear of smart recovery or all recovery or different types of pathways with meetings that go along with them. So trying to bring those meetings into the area that I'm currently at or currently working at is one of the things that I'm trying to do and have done.
Okay, they gave me a little bit more time. I must be doing good. Hey, Daniel, we got some time to talk. You want to chat about the things that you have done creatively? Let's talk about that a little bit. Anything creative? How are we engaging people with challenges? Or like some things that you've done, like sometimes we got to think outside the box, right? Sometimes we have to think outside of the box. Anything that you've seen or that you would like to do, because sometimes we got some people listening today. I've seen the state's attorney. I've seen some people in here that, how are we engaging? How anything creative or ideas, wish list stuff. Let's go.
So Daryl, is it okay if I hop in here?
Oh, absolutely. I was talking to you. Sorry.
So, All right, awesome. Sorry, it's a little breaking up a little bit on my end, but one thing that is one thing that I think is incredible, and I can talk all day about how important utilizing and really connecting folks that are in their early recovery or are actively using with folks that are in sustained recovery.
Right.
That's so important, right? So what we've done here at Duffy Health Center is really increased our capacity to have, again, peer specialists, so recovery coaches, recovery support navigators. At this point, I think we have close to 20 staff members with lived experience who are doing pretty much the boots on the ground work, working alongside our patients and our participants to be their support network, and also to try to support them before they need to get to acute care settings like the hospital, right? We rather someone give us a call and say, hey, I'm really hurting and I think I need to go to a detox, or I need to go to an IOP, rather than walking through the doors of the emergency room and having to go through that rigmarole. So creating access points to treatment, and then not just saying here's a list of places, have at it and have a good day, but having someone stand by you and support you with making those calls, figuring out how you're going to get there, what's your plan when you get back, what is going to be your recovery plan once you return to the community. Creating a recovery community when folks come back from active treatment, that is a huge thing.
Right.
And again, finding ways in which these amazing individuals with lived experience can kind of sneak themselves into all the community discussions is really important. So we try to infuse our individuals with lived experience into every conversation here on CAPE.
Right. And you know what? Since we got a couple more minutes, right? I want to talk about it. Let's go deeper. Can we go deeper? Can we go take a little deeper dive? Because you got people that are listening that say, "Man, Danny, this all this sounds great, but how do I go to my boss? How do I go? How do we get funding? How do we implement this? How do we put stuff like this in play? What's step one?" Lisa, let's talk about, like, any of you talk about, like, how do we implement it? Because I know when we bring peers in, man, that's a big sell. You ever try to get a peer program started in an organization? Well, what are they going to do? Are they going to steal the van? Or what happens if they relapse? Number one question when you try to get people with lived experience to get them into a facility, y'all can't be laughing. Come on, Richard, you know what I'm talking about, Richard. You know what I'm talking about. First thing they want to know, what happens when they relapse? What happens when Marge in HR has a heart attack? We deal with it. So that's part of the stigma. Right. So let's talk about implementation, because there's some people out there that's saying, we want to do this, but give us step one, step two, so they could come back to C4 and RIZE and we can walk them through it. But let's give them some steps. Like, what's the first thing? Where do we start? Step one and step two. Let's talk about implementation.
Daryl, before we do that, I'm just responding to some of the comments, if you don't mind. And I do think we should, pause and talk a little bit how we're engaging people of color before we talk about systems implementation, because it seems like that is a really, that's what we need to keep talking about, right? And I did chat in a comment just in case we didn't get to it, but I really wanted to be sure.
Hey, I'm Black. We could talk about Black people all day. Let's go.
If we could do that, I would really appreciate it. And honestly, I think we all need to do better, and we need to know that, right? We need to accept that in a non-defensive way and keep asking the question, what are we doing? Who are we not reaching, right? You can put wide open doors, like I feel like we have done, right? But if people aren't walking through those doors, it's not helping.
Right.
And so, it's really about kind of how do we engage individuals with in our communities that need our services, that aren't walking in our doors, that maybe don't know we're there or don't feel that their services are for them, right? That don't feel like this was built for them. And so, not that we have great solutions, because I think we need to keep working together on this. But it takes a lot of time and effort, right? But it's worth it. But engaging with kind of direct communities. So the example I gave in the comments, and I'll just speak to quickly, is in those two rapid access buprenorphine and naltrexone programs in Worcester and Framingham, both of those communities have started kind of a community engagement hub process, which has direct community staff going into communities, going into tented areas, trying to connect and reach with folks who aren't typically connecting with care. And so we've joined in with those groups so that we've actually sent staff, right, direct staff. And staffing is not an easy thing to do right now, but this is important, to try to engage folks and see, this is a service that's available. How can we help you? And I appreciate the comment coming in, right? Because if the staff don't look like you don't feel welcomed. And so we are actively, working to change that, right? Working to change that model and working to change the hierarchy that tends to happen in healthcare in general, but also in addiction treatment.
No, I appreciate that. I appreciate that. And you know what? I'm going to give you guys just a little tip, right? If you are in urban communities and you want to engage, because all the time you'll hear people say, well, we try, we just can't find them. Well, let me tell you, go to faith-based organizations. You need to be connecting with these faith-based organizations. You need to be connecting with the barbershop and the beauty salons. You need to be out there. And you can't, in some of those places, you can't get in if you don't look like me. So they're not going to talk to you. So let me tell you, you need to hire people of color who have been successful in the transition process and recovery. Shannon, you're not getting away without jumping in here, girl. Come on, man, let's go.
Yes, I actually have to piggyback off of what you just said, Daryl. I'm not a person of color. I am a white woman, so I can never begin to understand what a Black man or a Black woman goes through on a daily basis. I believe that some of the things that we need to work on is our languages, asking the uncomfortable questions, and having those uncomfortable conversations, right? I have a biracial daughter, and I'm never going to be able to understand the things that she's going to go through as she grows up. It's the same thing in the recovery community. The way I treat somebody that is homeless or addicted and hurt and in pain, I'm going to ask those questions. But unless I'm a person that has been through it, I'm not going to understand. So some of the things that we are doing at the Edward M. Kennedy Community Health Center on 19 Tacoma Street in Worcester is we are a very, very diversified community health center. We have, I think, a person of every ethnic that is present on staff there, especially in our MAT program. We go to the extent we even have things for LGBTQ community. We have a whole center that is above that. So it starts at home and it starts with us. And it's, I'm never going to be able to understand what, people of color go through. So what better to have someone that has been through it to be able to help assist that. And I do believe we definitely need more trainings for us to be able to understand and know how to help and things like that. So sometimes it's as simple as asking those questions.
Cool, I appreciate that. And
I would love to.
Can you guys hear me? My voice is good? Daniel, jump in.
Yeah, I would love to piggyback off what Shannon just shared, and also Lisa. I think that having a team that reflects obviously your community is really important. And one thing here at Duffy that we try really hard to do is to build a diverse team of staff members. Our community tends to be a pretty homogenous group. We tend to have a higher population of folks who identify as white. So what we are looking to do is to try to bring in as many community members of color, non-English, or individuals who have, a multitude of different ethnic backgrounds, have the ability to speak a variety of different languages, and also recognizing that for our staff members who are walking through the doors who may identify as white, that we need to have the conversation about what comes with white privilege, what comes with their ability to, walk through the world with, that sort of level of, again, privilege. And what does that translate out to when they may be working with a community member of color or non-English speaking, patient? So we tend to have pretty robust conversations almost on a daily about what's the intersectionality of that. And as someone who identifies as Hispanic, but very clearly passing, being able to utilize the privilege that I have in my role to advocate and to try to be a voice for, the community members of color here on Cape Cod. And continuing to bring that to the greater discussions is important, recognizing that we need to have individuals, as everyone has said, that reflect the community in on these conversations.
I appreciate that, Daniel. I've been to Cape Cod, and I can't tell you the anxiety that I experienced as a professional being in Cape Cod, right? So when we're bringing people in, we need to understand that there may be some anxiety that individuals are feeling, because that's not somewhere, like I also freak out around farms too. I'm a city dude, so any of that stuff freaks me out. But understanding the importance of diversity, right? Just having people of color within your organization is not enough. We talk about equity and working with individuals, and we haven't talked enough about this. So I'm hoping that we're going to talk about trauma, right? Because when you start bringing people of color or people from urban communities, even rural communities, anywhere that's dealing with addiction recovery, we need to be talking about trauma. Trauma is a huge part of my story. So how we address those issues and making sure that, for strategy purposes, those of you that are thinking about, we talked about implementation. And if we don't get to talk about it here, please bring it to your breakout groups, especially those systems people. You need to talk about implementation, because this is not easy. And then if we're talking about implementation, we need to be talking about equity at the same time. We need to be talking about inclusion at the same time, because a lot of times these programs get built and they're not built with everybody in mind, if you guys understand what I'm saying. And I think it was you, Shannon, that mentioned NA and AA. Let's keep it real. When the AA was created, it wasn't created for Black and brown people. It was created for white males that initially started that group. So they weren't even thinking equitable. They were like, oh, this is a great program. And then it became more and more of us started to walk in through those doors, and still they didn't change the programming format. It's still the same. You could be here, you got to identify a certain way. So how do we make sure that people that come from different places are well received and feel comfortable in those spaces? And that's what we're talking about. Anything else? Creative ways, barriers, implementation. Can we talk a little bit about implementation? I know each and every one of you have said something that you've done and some of the barriers, but like, what was step one? What did you see? Like, when I see something, I was taught this, and I was taught this early in my career. If it doesn't exist, create it, right? And I thought that was brilliant. But then I found out how hard it was to do that. So let's talk about step one and step two. Can we do that?
Yeah, I'm happy to
Step
talk
one.
It's hard, right? And you have to be willing to do the hard. You have to be willing to see what might be possible or what you'd like to see change, and then just start from the ground and start taking steps towards it. I think a good example of that, and is something that comes up in the paper quite a bit, right, is that access to care in correctional settings. Right? Instead of saying this is an impossible setting to work in, this is never going to happen. It's a stigmatizing setting. It's all like, and just not dealing with it.
Hold on, Lisa, could you say that again? I'm sorry. Could you say that again? I'm sorry. You gotta say that again, because somebody went to the microwave while you said that. Could you say that one more time?
Yeah. So just, you have to be willing to kind of challenge kind of what is possible. And I think that, providing care in correctional settings is a great example of that, right? If you had asked any one of us, 6-7 years ago, if we would be providing, medications for opiate use disorder in state and county facilities, and people would have access to care. I mean, I'm not sure I would have believed it, right? Like, I'm not sure that I would have believed that. So what I, want to kind of put out there is you have to believe that that's possible, and then start taking steps towards making it possible. We're not 100% there yet, right? We've got some room to go. We need to make sure that it's equitable access across, all facilities, that everybody has access upon entry into incarceration, whether you're on a medication already or not. You need to start one, or during incarceration, and of course, preparing for reentry into the community. But we're getting closer because we just, believe that it was possible. So the legislative process that's starting to make that possible was because somebody believed that that should happen and push that agenda forward. And providers need to do the same thing in order to go down that path and be part of that system, and start to break down that stigma.
Appreciate it. And any of you that have people that just come home or just walk in your office fresh out of prison, I encourage you to say welcome home, because no one ever says that to them. So say welcome home. And we at C4 and RIZE and the RIZE community, right? We believe that reentry begins at the beginning of the sentence and not the end. Shannon, talk to me. Implementation or anything like that. I mean, the chat box going crazy. I mean, it's on fire. My fire alarm is going to go off in a minute. But jump in.
Let's keep it real here. You have to know somebody to be able to make changes with anything, or know somebody that knows somebody. So some of the things that I've done is any event that's in my area, whether it had to do in the recovery community, or it had to do with the police, or it had to do with the court system, or it had to do with City Hall, I would join and I would start making friends. Because I mean, I'm only one person. I have a big mouth, don't get me wrong, and I will scream at the top of my lungs, we need to make these changes. But in order for me to be able to do that, I have to be able to move my way up the ladder. I have to be able to know somebody in the, in City Hall, or in the justice system, things like that. So making those relationships, I think, are a huge thing. And I have done it in, the matter of, just these, I'd say my last 5 years. I've gone to every event I possibly could, and we've been able to get MOUs, memorandums of understanding with the Shirley Police Department at my last job. With some of the, like the Shirley Parole Board, we were working with them so that when an inmate that is on medication is paroled, they can go straight into continuously getting their medication. Things like that I've done at the last 2 jobs, and we're working on new things at my new job now, like trying to work with the Worcester District Court, especially in the probation department, getting a memorandum of understanding with them as well, that when somebody gets arrested and instead of going to jail, they're put on probation, but they suffer with opioid use disorder, let's figure out what is best for them. And not all probation officers are going to sit there and ask those hard questions. So why we're trying to make that relationship so we can sit down with them and say, hey, I'm a person in long-term recovery. I can identify with you. How can we help you? Let's, and some people don't always know, right? I didn't know how things were going to help me in the beginning. I had to have been given different options to try out, different meetings. I tried methadone, I tried Suboxone, I had to figure out what was right for me. So giving those options to probationers and parolees, I think it's a huge thing, and it's a great start, right? It's just the start though. Am I correct? We have done a lot over the past few years, but we still have such a long way to go. If I can recommend doing anything, it's don't ever stop speaking up. Don't ever stop having those uncomfortable conversations, because that's the only way to make change, whether it comes to opioid use disorder, or it comes to stigma, or it comes to people of color. We all have to continue to talk about it and start making some changes.
Man, nobody told me we were having rock stars on the panel, man. I should have dressed up, man. I could have got a little bit more fancy, but let me tell you, and I appreciate that, Daniel, I'm gonna bring you right in. But one of the things that Shannon, you said, it was about finding that champion, whether it's a champion within the correctional system, because there's people like-minded, whether they have family members or whatever, they talk the same language as us. They think like us, right? So we got to find that champion in the legislative building or what have you. And then it's also important to teach our people, those of us that are in recovery, that sometimes when you're testifying, you only get 3 minutes. So we do that. We would like to work with you to show you how to craft your story so it's important and you get it in and get it out. So make sure that if you want to learn more about that, reach out to C4 and talk about that in the RIZE team, because that advocacy, sometimes you only get a short minute and everything is not a meeting. You got to be able to bang, this is my point. My name is Darryl McGraw. I'm a registered voter and this, and that. Sometimes we only get a hot minute. Daniel, talk to me, brother.
Yeah, so Shannon took many words out of my mouth. 100%. I think knowing people, getting to be out in the community, getting to really, start to build strong relationships is really important. And what I will say, and my team knows this very well, is I will call myself a con man. if I see something and I want it, and it has to do with making sure that that the folks that I'm trying to serve, it's going to be in their best interest, I will scratch, claw, I will figure out how to make it happen. And I think what that means is presenting and making the connections in a way that, the goal and the dial is being moved forward, right? So, one crowd is talking about best practice. This is important because of this. My sister Shelby from Peer Recovery threw in the chat that, on CAPE, we need to work together, right? Sometimes agencies and programs need to put their pride aside and just say, we're all doing the same thing here, and we need to build a community and not have a turf war, and we need to try and figure out how we progress together. So then that way we're creating a space for our folks to thrive rather than survive, right? So one thing that is important for us here, at Duffy, and for the work that we're doing, is to try to establish relationships with a multitude of different community members. We have some work to do because we fall short at times, but making sure that any way in which we can create a relationship that may be in the best service of our folks. And if we want to have this thing happen for our folks, who else do we align with? So then that way there's multiple voices tackling the same issue. That's where there's more, there's power in numbers, right? Implementation, system change, that doesn't happen in isolation in my viewpoint. And it takes, again, I think, a team, a family, and a group of folks to be able to push certain things forward.
Right.
Can I just, I'm sorry. I was the one that made the comment. So I just want to say, Danny, thanks for commenting back on that. And I'm seeing a lot of people on the Cape nodding their heads. Real quick, without some people coming in or us going out, it's unbelievable. We're all under a lot of the same funding, right? But, we've got the peer navigator at the courthouse. We just revisited. He can put people who are coming from jail, I believe, or needing to go back. We'll set up sober housing for people if they need to go into treatment. Things that we don't know. There's another gentleman on here who stopped in just to see us, and he was able to get a gentleman who was just out, he was incarcerated, dropped off at the bus stop about a month ago, and he's relapsed. And we were able to get him within 3 minutes into a treatment facility because we all work together. And that's where I think the big piece is, Daniel, we need to get together. How can we help you? How can you help us? All of these things, it's just, we're all here for the same reason. And, people will come and they go around on the Cape and they'll do different things. And they come back and they're like, oh, this person did this. And I'd rather have the actual straight voice and the go-to of, okay, how can we fix this? Because people are doing what they need to do, but people are telling us different.
Shelby, listen, you trying to steal my job. You're about to get me fired, Shelby. Listen, man, you going rogue in here. We know y'all doing it on Cape Cod. Listen, I better see you in that. I better see you in one of those breakout rooms, bringing some of that good energy in there, because we need that. We need that. I want to make sure though, and thank you for that, because it's important. Because you know what, there's a lot of misconceptions about recovery in places like Cape Cod, right? They think that it's just rich, and they think that the narrative, but we're everywhere. We need to be helping people everywhere. One of the things I want to make sure you do before I bring on Cheryl, my homegirl, Cheryl Gagne, who's going to take y'all to the next level, is that I want to make sure each and every one of you take something away from this and read the Learning from Lived Experience. Also, this is a tool, right? Thanks to Justine Hansen, right, for helping us put it all together, right? But you have that infographic that we shared. Take that back with you. Look at it. Look at that roadmap. Look at those things. Use them as conversation when you're trying to initiate these conversations. Use these tools. And you're not alone. This is a we thing, and this is not a one-off. This is a network. I'm a firm believer in my network is my net worth, right? So all of us together can make change. Like I said, somebody is struggling today that this meeting is going to help tomorrow. So let me just say that. And Cheryl, you in the building? Cheryl, where you at?
I'm right here. I'm here.
Let's go. Let's get it, man. I want to thank my
All
panel.
right.
I want to thank my amazing panel. And Cheryl is going to take us to the next level. I appreciate you all. Thank you so much.
Thank you, Daryl. Hello, everyone, and thank you so much for your participation today in this important summit on learning from lived experience. My name is Cheryl Gagney, and I'm a senior associate at C4 Innovations. And right now we have an opportunity to continue our discussion this morning. You'll be asked to select a breakout group that resonates most with you. Right now, the groups are organized very kind of generally into buckets of people, programs, and systems. So if you're most interested in kind of addressing issues that, you know, maybe address the learning needs of providers or the information that community members have that really focus on increasing the knowledge, skills, resources of people directly, you're going to choose that bucket. If your passion is more with programs and program improvement and how can we really fine tune and improve our services, addressing policies, procedures, practices within organizations, then you'll probably be happiest in the program group. And then finally, if you're more on a systems level kind of thinker, someone who thinks about system level barriers, you're going to select that group and perhaps discuss things like policies and laws and funding, networks of organizations. Of course, if you're totally unable to decide, you're welcome to close your eyes and push a button. You'll end up in a group which will welcome you, and your ideas and comments will be welcome as well. So looking forward to this section of we have about, I think, a half an hour, a little more than a half an hour to continue our discussion. So we'll review these when we get into the breakout group, and many of these go without saying that, you know, kindness and courtesy is welcome. I've noticed in the chat box today lots of support and you know, people commenting on other people's comments. We'd like to focus on solutions and strategies. Can be hard after talking about barriers, but as much as we can to really focus on what next, what do we do about this? Hoping that we can advance the conversation and welcoming a real diversity of thought and opinion in the room. Okay, so we'll be asking these questions. There are 6 different breakout groups, probably 2 of each, 2 addressing people issues, 2 for programs, and 2 for systems. And we'll look at strategies and solutions that resonate with you. I like the idea of coming up with a strategy that is low cost, no cost, that you could do tomorrow in your organization. And then thinking in terms of longer term solutions or strategies, and how you might implement these in your practice. Actually, there are 3 breakout groups, right? Okay. All right, I think now we move to breakout groups.
Well, I want to say thank you to everyone for your participation today. And I think we're going to turn it back over to C4 for some feedback from the breakout sessions.
Okay, this is Cheryl again, everyone, and I'm hearing from breakout groups. Anybody from the people breakout group want to talk about the conversation you had?
So Cheryl, thank you for asking, and I'll start, but I really, if any one of my team members wants to chime in, absolutely.
Okay.
But for us, it was really around education, being able to understand sort of the recovery journey itself, but for us, the value that education brings, not just in terms of being able to find a job or employment, but the kind of education that helps an individual gain a better understanding of who they are, what the process of recovery was or is, and what are the things that are impacting them. And as we kind of talk through the education piece, you know, we ended up on stigma because that's where it goes. So the education issue is massive. for all of us, because it means that it gives us a fighting shot at overcoming some of the challenges, particularly if we've got criminal convictions. And then the discussion around stigma. There's one other thing I want to add. The stigma discussion is what all of us, I think, really know about stigma and bias, because it's pretty predominant in the work that we're doing. We understand that. But Anna brought up something I think that's super important. And we were talking about paying peers what they're worth. And one of the things that Anna mentioned was that peers, at least in her sort of sphere, do a lot of volunteer work on panels and yet can't find a job. And I told Anna, really the onus is on the provider. I know that C4, we don't ask a peer, a person with lived experience, to present or speak without a stipend, without paying them. And we pay them the same amount that we pay anybody else that would come and speak. Now, you can donate some of your time, but for providers, it's really important for us to recognize the value of that experiential knowledge and to be able to pay that person the same amount that we would pay any other professional. So that was really the focus of our group. I don't know if my group members have anything they'd like to add really quickly, but I'll step out of the way.
A couple people have put things in the chat.
I'll just jump in really quickly on that note that Stephen had brought up. I think another thing that we were talking about in terms of paying people is making sure that lived experience in kind of more corporate roles or whatever role people are entering into, that is seen as important value, and maybe even as important as a master's degree, whatever educational experience you have. I know plenty of people in recovery who have gone the peer recovery coaching route and have said, is this the ceiling? Is this the cap of what I'm going to be able to make, like, financially in my lifetime? And want to kind of pursue further opportunities, but are noticing that every job application that they see is requiring a master's or requiring something that is not having lived experience. So I just think that that's so important. And as allies of people in recovery, as friends, family members, and as policymakers, people who work for organizations, it's so important that we try to change that and make these roles accessible to these very, very qualified people.
Thank you, Anna. Anybody else?
Okay.
All right.
Well, so then we'll go to the program group. Anyone from the program group want to?
Sure.
What your group did? Yeah.
Sure. So we had a great discussion. This is Libby Davis. Hello, everybody. And I was joined by Sarah Merrifield, who was also on here, and a fantastic group of people. And one of the things that first came up was as something that people really want to do to overcome barriers is collaborating, working together, and really focusing on authentic, intentional, and urgent collaboration, and creating the space to do that. But also, how do you as a program elevate the importance of outreach and understanding how can you collaborate, and how do you do that when you are working with people who are in front of you who have crisis, and how do you prioritize, how do you add resources to make that happen? We also heard around collaboration that, we all know siloing is a continued huge barrier. And so if we could commit to collaborating, then, we will actively break down siloing. So it's important as a strategy to decrease siloing. It's important as a strategy to make sure, what are the services and supports available to a person that we can't meet as an agency. And it's also a way for us to learn, right? So really paying attention to collaborating and working together. And also not just doing it for the sake of collaborating, but having urgency around it. So that was a big piece. We also talked about, it can be a barrier if you're in a program to go to your boss or to your administrators and say, hey, you know, I know this is how we do it in our programs, but can we look at doing things in a different way? That can take courage depending on the position in your agency. And so how do we best do that? So we don't necessarily just stick to what we're always doing. How do we raise that voice? Another specific barrier that was mentioned was, you know, how do you make sure that privacy needs don't get in the way of collaboration, right? If you look at 42 CFR, the confidentiality, you know, what kind of releases might you need in order to collaborate effectively and not violating the privacy, right? So we had some specific strategies that we discussed around how to overcome barriers to collaboration. So some of them have to do with privacy, some of them have to do with program resources, and some of them have to do with changing the culture for ourselves. We also talked a little bit about, you know, how do we meet people where they're at? And how do we better collaborate with emergency rooms or with each other to make sure that you can start treatment or medication in one place and have the care continued throughout the continuum. We also saw a lot of sharing of programs and emails in our chats to say, hey, I want to know more about you, or hey, that sounds like a great strategy. So it was great to see some active collaboration happening in the chat box as well. And I think also we had some specific program suggestions, program needs. How do I add a recovery program to my program? What does that look like? So good connections around that as well. And also trying to understand, why might people not want to collaborate? Is it because of lack of resources? Is it because of lack of time? Or is it because we're a little worried about scarcity mentality for funding? What is it? And again, that gets back to having real conversation, authentic conversations, and taking the time to get to the table. So that's just a little bit about what we talked about. Please, anyone else from our group, chime in. I tried to capture some of the highlights.
You must have done well. No one has anything to add. Very good. So I'll report out on the system level group. We too had a very dynamic group, lots of conversation in the chat box, and some of the themes were the same as you and Stephen mentioned, interestingly enough. One of the solutions that came up, or strategies that came up with a couple of examples, was about going above and beyond. And some of this was stepping outside your comfort zone. Some of this was connecting with, you know, people you might not talk to, insurers, you know, somebody in HR, somebody who's not, you know, necessarily working in your lane, but connecting with, you know, champions, people who can partner with you. So collaboration was a big part in the on system level, you know, systemic change of really needing kind of a diverse group of partners. The other kind of statement that was mentioned is that we're all in this together. And that really is the theme of cooperation, collaboration, as opposed to competition. And unfortunately, you know, with some things on the system level fall apart in terms of networks of care because of ongoing competition. There were some very specific strategies around legislation and methadone that were mentioned, both federally and statewide, and trying to increase the number of take-home days and ultimately perhaps having methadone available in pharmacies. The ongoing lack of parity despite laws, there hasn't been, you know, real parity in behavioral health. And are there ways in which legislation can add a few more kind of teeth to that law? There were a couple other issues around, and this was almost a hurrah, we've done something, you know, system change. And that was in the criminal justice system, of really looking at what it took and what it's going to continue to take to make certain that everybody who is in need of medications for opioid use disorder, who are incarcerated, have access to that and high quality programming. We've made a beginning, you know, and it's been a very ambitious and quite more successful than most people would have predicted start. So, so those were the themes. in our group. Does anyone from the system group want to kind of add anything? Okay. Well, thank you all so much for your participation.
Great, Cheryl. Sorry, I was stuck for a second. Thank you, Cheryl. And I think we have 2 minutes and I'll take us home. This is Julie Burns again from RIZE Massachusetts, and I want to thank you all so much for such a terrific event today. This 2 hours went by really fast, and I saw a lot of comments in the chat that this could be a day or more, and I think that's something for us to think about. This was just super. Again, thank you to the panelists for sharing and your very candid comments. I appreciate your willingness to speak out and speak up, and I hope that you'll continue doing that. And I always want to say a special thank you to Daryl and Cheryl and Livia and the team at C4, and a special shout out to Justine for writing the paper, which I hope you'll all download and read. But this was really great. You know, by eliminating barriers, more people are going to seek treatment. They're going to have access to treatment, and they'll be given the resources and the help they need to be successful on their journey. But before I sign off, I want to tell you about a couple more programs at RIZE, if you're at all interested in joining us for those. On Thursday, April 7th, we'll be hosting the second of a two-part series in partnership with the National Harm Reduction Coalition and the Kraft Center for Community Health, which is focused on harm reduction in housing. During this program, we'll be hearing from peers across the country about partnerships and approaches that have developed to actually make harm reduction and housing work together and save lives and keep people housed. First, those social workers out there who are learning more about harm reduction and how to help reduce stigma associated with substance use disorder, please join us. Again, with the National Harm Reduction Coalition and the National Association of Social Workers, for the first of two trainings around harm reduction that will be held at the National Association of Social Workers Massachusetts Symposium on April 28th. And if that isn't just the fact that it's going to be a great program isn't enough to entice you, social workers can receive 1.5 CEUs for each session they attend. So please, if you're not already on our email list, please sign up or follow us on our social media channels, Twitter and LinkedIn. And so you can stay in touch with us and learn about what we're up to. But I want to thank you again. Just a reminder, after the closing of today's program, you'll be prompted to fill out a survey. Please take a minute to do so. Hearing from you really helps us improve our programming and design future events. And we always really do want to make sure that we're staying close to those of you on the ground that kind of know what's going on, know what topics you want to hear about. So thank you again and have a great day.